Okay. Okay, let's go ahead and just get started. People will trickle in as we get going. And so I will preface this by saying that this is something that was kind of born out of necessity based on essentially like a focus group of our IM preceptors that we had where we all sat down and we talked about like what everyone does for presentations and how we incorporate educational initiatives, and everyone had a different style. And even the styles that people were tied to, they weren't exactly happy with. And then Dr. Adams made a mention that they were using a different style that Dr. Steinhilber will tell us about. And this is just a way to give people a little bit more information on different ways to have your residents present. It's a way to get residents to be on the same page. It's a way to get attendings on the same page. I think it will be really nice. This will be recorded and we'll put it onto our own personal kind of YouTube page so that people can watch it down the road, because we're going to have to tell the incoming interns about this as well. But
Mhm.
so I will start off, I think, mostly by introducing our guest lecturer. So this is Dr. Steinhilber. So she comes to us from the University of Alabama in Birmingham. She did her undergraduate at University of Miami. She did her medical school at UAB. Then she did her internal medicine residency at UAB, and then did a chief resident year. So she joined their division of general internal medicine, and she really focuses on teaching people to be excellent clinician educators. And she's also heads up their quality improvement track as well. She was just, I think, last year awarded a major teaching and academic award chosen by residents and medical students alike. And we are so happy to have her as she kind of walks through this, and it will make more and more sense why we're talking about this, I think, the further we go along. But Dr. Steinhilber, I will pass it off to you.
Perfect. Thank you so much, John. I'm going to will you unshare and then I'll share?
Yep.
Okay, perfect. Thank you. Let me make sure I get the right one. Okay. I think we're good. Um Thank you so much. It's so good to virtually be there. I do wish I would love everything, including interview season, to get back to in person. And so then we could do everything in person. And I recognize so many names actually from the list of participants from AIM Week and former like program director conferences, which is just so fun. Thrilled to be talking about this. I am very much in the med ed and QI space. And so this merges two of my loves, which is streamlining things, making things more efficient, and then learning how to kind of research that and make it better. So I'm super excited to be here. And then Dr. Logan, I guess, mentioned residents. So I'm glad residents are on. At the end, I'm going to show you all of our tools that if people want to do this at different institutions, we have a whole website so that people can just take and run with it. And there are tools for orienting faculty and orienting the residents. And so I'm going to have like do that today, which is great. So you won't have to orient or teach any of them because a lot of the slides are similar so that you've seen it once and then it's easier to use slides if you've seen them before. So that's our hope. Um, so, with that, he mentioned I'm one of the APDs for our residency program. Big fan of the resident stage in life, mentoring, and just making that whole section of those 3 years better. And so that is kind of my whole goal and what I love the most. And I do direct patient safety and QI. I'll just make a brief mention of my other two collaborators on this because this was really a long time in the making. Dr. Kramer is our program director, and then Dr. Snyder has been our ambulatory APD for many years, and also the director of one of our clinic sites. And so that was, I'm doing it solo, which is great, but they are very important. I'm not told I have to have a disclosure slide, but I feel like everyone does. And so I did. And I also think I have to say something about the fact that one of our clinics is at the VA, and this is working very well in that clinic, but has nothing to do with the VA. So I'll just mention that in case that's important. And then my learning objectives are to recognize, so we'll recognize the limitations of the traditional SOAP style presentations for teaching in clinics and having presentations by residents in clinics. And then I'll demonstrate how we got to a problem-based presentation, what it is exactly, and then how that is going now with some of the benefits and outcomes. And so I did talk about we got residents and academic faculty, which makes me so happy. I think this will be even better having both. And we'll kind of go through why we did it and what it is. I will hit on a few of the frequently asked questions before maybe asking you guys for questions because some of them that come up are very similar. And then if we have a moment, I'll talk about how to bring this into notes. Um, And I should have asked Dr. Logan before when we were just chatting, but will you, or you could pick on someone if there's a chief on the call. Tell me what the resident clinics are like there, meaning how many sites, how many preceptors, maybe ratio, and what the setup is.
I think I saw Bridget Melinda, and I
I
feel like this is just
I
a
knew you
wonderful
were gonna
time for
pick on
Bridget.
me.
I know she's my go-to.
I'll turn my camera on. I'm sorry, I'm eating. I like knew the minute you said chief, I was like, okay, John's gonna call on me. Basically, so our clinic sites, we have two clinic sites. We have KU and the VA, like you see there, and our residents will stay with the same preceptor all 3 years.
Mm.
And so we're a 3+1 model, and so they are in their clinic week every fourth week. They have 4 half days of clinic. I think it's 4 half days of clinic, same preceptor. Intern year, you see up to maybe 4 patients, I believe. And then that expands as you go along. I think by the end of your third year, I think you can see up to 8. I'm sorry if I have those numbers wrong. Um, and like I said, yeah, you're with the same preceptor. We typically, I think, in terms of presentations, it's very dependent on, it's just preceptor preference. And so kind of like what John was saying is kind of, I think, what helps to prompt this
Hmm.
presentation today is to try and help to standardize that. I don't know, any other information
For
that
the
might be.
preceptor, is it just one resident, one preceptor, or are there
All
multiple
right.
there at a time?
There are 3 to 4 residents in a group with one
Okay.
preceptor. And so
And so
it's
if one's presenting or checking out or presenting to that preceptor, are the others waiting like for their turn?
correct.
Okay.
Yeah, yeah, yeah. Or they're like with their patient or whatever.
Okay.
Your intern year in the first 6 months, the preceptor has to see the patient with the
Mm.
intern, and so that also contributes to time management
Yeah.
throughout the clinic day.
Okay. That's so helpful, Bridget. Thank you. Thank you
Mhm.
for letting him pick on you.
Yeah.
That's great. So we all describe ours, which is somewhat similar and why we were pretty scattered, we felt. We have 2 sites. So our university site has one faculty member and then up to 4 residents in that clinic. We are not very good at the continuity because we are X plus X, I don't know, 4+4. It's not quite the clinic week. And so, like, for example, I am in our university clinic site on Friday afternoons. And so, whoever got scheduled is going to present to me and staff people with me. And I see multiple residents often, but it is not a standard kind of you're always Friday, I'm always Friday. So that's a 4-to-1, 4 residents to one attending, but only one attending over there at any given time. Our VA site, on the other hand, is the largest group of our residents, and there are 4 attendings there in one room. And then you see your patient, and you basically come in and present to whoever is available. If there's like an empty seat, you sit there. We try to keep continuity with whoever's going to do your mid-year and end-of-year clinic evaluation. But if that person's occupied, just go to the next one so we can keep flow going. And so you can imagine how you have 4 different preceptors in one room. And so what different people want, you don't really know. And interns certainly have no idea. They've never met these people. They have no idea. And I'm at that clinic site too. So there's just a lot of variability. And we realized that through time. And so we decided to try to fix it. So that's what we'll talk about. And I don't know, I didn't ask, and you don't have to come back on either John or Bridget, but our faculty are pretty much the same faculty at both clinic sites. So I don't know if yours are the same or different, and if you would have to kind of talk to both, but ours are the same, which is nice. So we have one standard across both clinics.
So I
So,
will say that ours are completely separate. This is like
okay,
Amy Brubaker's
really,
like
okay.
this puts a fire underneath her because we have these completely separate clinical responsibilities and attendings at different sites. And so only 2 residents per year are chosen to go to the VA. And then
Oh,
the
okay.
other 22 or 23 per class are at the main campus.
University side. Okay.
So totally, totally different. And then I just want to make a point. So we have all that continuity with the single preceptor, but then it almost makes it worse because it's like when a new person comes on to take your presentation after you only have 2 weeks where you're not with your preceptor who's assigned to you. And then it's like you are really not used to presenting to anyone else. So
Yes.
yeah.
Yeah.
So continue.
I could see how you have the same preceptor for 3 years, so that's good. So you get used to their version. and you don't necessarily need another version. Like we felt like we needed to, but it is probably good for have, especially expectations. And when you're asking everyone to do evaluation and they're like, well, they never tell me that and I don't want to know. And this other person says, I ask them every time. And so I dock them on that thing. So yeah, great point. So cool. So when we ask students and ask residents, how to present in the hospital, and if I asked all of you guys to put it in the chat, pretty much everyone, is going to say SOAP. So, right. So subjective, objective assessment and plan. And for those of you who might have been, a little bit in the wiser generation, we always had a Maxwell's, which was in your pocket, and that told you how to do admission orders. This was all when everything was on paper. And so part of that was how to do a daily note. And this is kind of what it describes. So SOAP, and everyone knows that. So we're very standardized in our approach to that. But then in the clinic, we found that is that the same thing? Our residents would have a lot of questions coming in. Interns would of, okay, do I present a new patient the same as a return? Is that different? What if they're not new to the clinic, but they're new to me? Because this is, July 1. What if they have more than one problem, which everyone in clinic has more than one problem? What if they had chronic diseases, and how is that different than their acute problem today? And how do I fit all these things? And then you want me to do some preventative health? Like where in the world does that go? So people would get very lost very quick trying to use what they knew about presenting in the hospital to try to fit that in clinic. And so we really wanted to kind of help standardize that. So our goal was to build a better presentation to improve resident, the education and the experience. And so what we did, I'm going to go through all these parts, is first we did a needs assessment. Then we kind of created this problem-based presentation, and then we evaluated it after the fact. So going through those, the needs assessment. So this goes all the way back like 10 years now. So in 2015, it was really Dr. Kramer, and I just finished my chief year, and Dr. Snyder. We had a lot of confused interns, and then we had a lot of senior residents that were like, oh, I got clinic. This is easy. Why are y'all confused? So we said, okay, let's try to figure this out. Let's see what third years are doing versus interns and how we can maybe try to make it better and make it more standardized. So with our incoming class, we surveyed them. The number of 60, we have about 40 categorical, and then that include all the anesthesia, neuro, and med peds that also are with us for a year, in 40 different schools. And that's what we wanted to know is, what were you taught coming in? Before we tell you anything, what did you come out of med school knowing? So we had a pretty simple survey. How were you taught, and were you taught to present the inpatient and outpatient? And so when we asked, okay, how do you present for an inpatient admission, they had that down pat. The H&P, everyone had that. Great, 100%. Subsequent day was the SOAP note, 98%. That was great. And then you can see it kind of trails off from the acute outpatient, one problem, which SOAP kind of fits okay in, and then the follow-up visit, a little bit less. And so we learned that nearly everyone was taught and remembered the inpatient stuff, but maybe not so much outpatient. And we know that most clerkships also focus more inpatient. So it's not necessarily that people aren't trying. I think it's just a matter of all the differences and all the experiences. And so here's some of the quotes, which are always kind of fun. So this is our focus groups. And the question was, how do you present to faculty and clinic? These were our interns. And so actually, these were more of our senior residents. One said, so when I was in medical school and probably early in my training, I stuck to the subjective, objective assessment plan. So going through their whole story, then their whole physical, and that's great for when you're early in training, but it's obvious that you lose the attention of who you're presenting to very early on. Another one said that full formal presentation that we're all taught early in training is not efficient and does not serve us or the patient well, given our time constraints. And I know everyone on this call feels time constraints in clinic. And then third was, I get stuck on those things that I'm not sure how to treat, but I actually need help with that. And so we kind of get sidetracked, and then it's a cluster of speeding through the rest. And I imagine most of you can have similar experiences to this. So that was, how do you present? And then we asked their experience with interaction with attending specifically. And our residents, again, these were PGI 1, 2, and 3s. So there's high variability between attendings in terms of how they approach resident education. I've been in clinic enough now to know that different attendings like it different ways, but they never tell me, which of course we laugh at, and I'm guilty as any. And then someone said, I don't really understand. I don't know if I'm doing it right or not. No one's told me one way or the other, so I'm just going to keep doing the same way until someone tells me otherwise, which is fair. So that was the first needs assessment and the first survey and focus groups where we said, okay, obviously there's not standardization here. Let's try to formalize this and see how everyone feels and see if we need to change it. So speeding up a few years, we did a survey in October of 2019. And we surveyed our residents. So we had 113 respondents out of about 120. We did bribe them a little bit to do the survey for us. A good mix. And that PGY 3-4 or MedPeds, PGY 4s. And then we also did the general medicine outpatient faculty. We have a large hospitalist presence too, but we specifically did our outpatient faculty. So I'm going to show you a few of the key kind of pre-data graphs, and then I'll bring them back at the end for how it changed. So the residents, here are the resident responses to some of the key questions. We asked, how often do you change the format of your presentation in clinic based on different attendings? And you can see kind of darker to the right as always. So most are doing that sometimes, often, or always. So they look in the room, they see who they're about to talk to, and they try to think, what is that person like? Based on how they've presented to them in the past. We asked, how confident are you in what the attending wants to know, inpatient? And they're like, very confident. I got this, inpatient, no problem. How confident are you in what the attending wants to hear, outpatient? Not as much. So it skews to the left, back to the middle, not as confident. And then how confident are you in what order they want to hear inpatient? So what comes next? First is HPI, then is past medical, and everyone seems to have that. And I'm sorry, I couldn't get the key to line up, but right is more confident. And then same, it skews more left when we ask them, do you know what order to tell us things in an outpatient presentation? And they said, not as much, less confident or neutral. And then the last resident one was, how organized do you feel? And it's kind of in the middle. Some people said neutral. Some people say not organized at all. Some of the third years, most of that on the organized were third years who had kind of finally figured it out. So those were our resident responses. We had similar questions to the faculty. And we said, do you have a preference for resident presentations in clinic? And 75% yes. And then we said, do you tell them? And not necessarily. So no one always orients them to what they like. And then it kind of is a vast kind of varying between the other options. So everyone has a preference, but no one was really telling people their preference. We asked faculty, how often does the organization of the presentation in clinic negatively impact your ability to provide good patient care advice? And that was kind of between rarely and sometimes. And then how often does the organization of the presentation impact your ability to teach something to the resident? And that's still kind of at least 45%. Sometimes it affected it. So with the focus groups and this, we came up with a few goals. We wanted to help residents feel more organized and actually be more organized before presenting their clinic patient, help them know what to present and in what order, help the precepting process be more efficient for both sides. And we really felt like if we could accomplish this, it would decrease the cognitive load so faculty could focus on patient care decisions or teaching pearls if you weren't sure kind of where the presentation was going and how long it would take. So with that, we created what we call the problem-based presentation. And y'all probably said to people inpatient as well, like we don't do organ-based like surgeons do, we do problem-based. So it's very much the same thought. So what we teach first is we want to start with an opening statement. A key tenet in medical education is setting expectations. And you can't really give feedback if you don't set expectations. So the opening statement is like a map of what we're going to talk about in this presentation. So I feel like residents on the call, have you ever had the experience where your attending is deep into a teaching point about the intricacies of the shoulder exam and you're starting to twitch because you know you need to talk about their active angina and they're like super excited about the shoulder exam? And then alternatively, faculty, I've had this experience where I am like silently applauding myself for how well I just cover the differences in calluses, corns, and warts in 10 minutes, only then later to be told that the patient has new palpitations and a current heart rate of 200. And so the opening statement is hoping to avoid that, is hoping to set the stage of all the important things we're going to cover so that we don't take up your time on something that may not be as significant today and that we kind of both know exactly what we should talk about. So what's included in the opening statement in general is who's the patient, how well do we know them, and what needs to be discussed. So specifically, we ask our residents to tell us name, age, and major medical issues. Is this a new or return visit? And when was their last visit? Is it new to any doctor, or is it new to the clinic, or is it new to you? Because that helps us know, okay, if I ask you all these intricate questions, you may have never seen this person before. And so it helps us gauge how much you should know versus I've seen them for 2 years and this is the seventh time I've personally seen them. Um, and then issues that were addressed today in clinic, and specifically if you need help with something, letting us know that. So again, we don't spend our time teaching you something we're excited about, but that you didn't necessarily need today. And then we've kind of added this asterisk to please let us know if you're very behind in clinic, because we do want to help you get through your list and not be stressed about that. And we love to teach. I'm sure all of your faculty love to teach, who are the clinic preceptors, but sometimes there's just not time for that. And we are also okay with that. We just need to know. So an example of an opening statement would be Mr. Smith is a 76-year-old with coronary disease, heart failure, last EF 20%, diabetes, low back pain, who comes in for a return appointment today. He was last seen in resident clinic 2 months ago, but this is my first time personally seeing him. We discussed his shoulder pain, back pain, and diabetes, and I could really use help on the shoulder pain. And so now we know, okay, those are the big things you talked about, and which one I need to focus on. But letting us know the other big kind of problems in that opening sentence is really helpful, so that if we go through a whole great teaching session on what to do about hypertension and we make a plan only to hear later that they're end-stage renal disease and we need to undo that plan, it's kind of nice to include those. So even things that previous transplants, things like that we are not managing, it's still nice to include, because that helps your preceptor know that you knew that, and that's kind of part of your thought process, and in case it affects any of the diagnoses that you will talk about today. So for this, in the inpatient style, how someone would have presented Mr. Smith would have been all of the subjective, right? So here's the subjective: he feels well for his shortness of breath, or for his heart failure, no shortness of breath or edema. He still sleeps on 2 pillows. And then we go into diabetes. He doesn't check his feet regularly, has not been to the eye doctor. And then let me mention all the subjective for his shoulder. So you do all of those, and then you give us all the objectives. So all the vitals, the physical exam for the edema, maybe the heart exam, maybe the shoulder exam. And then you come back to the assessment and plan. And we've got to remember, and you've got to remember what you told us in the subjective about all those things, maybe even 10 minutes ago, depending on how long this is taking. And so instead of doing that, we felt like, could we just batch them? And do the subjective of the first problem, the objective of the first problem, and the assessment and plan of the first problem, and then move on to the second one and the third one. And I know this seems simple. And what we found was in our focus groups from the very beginning, this is what third years, end of year residents who are about to graduate were doing. They had just figured it out along the way. And this was much more efficient and was better for both parties. But they had to figure it out in their own time and along the way. And we thought, well, if this might be what's best, let's just move it up and just start teaching it. So it's nothing earth-shattering or groundbreaking, but it does move it up about 2 years for interns to feel a lot more comfortable a lot quicker. So for Mr. Smith, he's the one, they discussed shoulder pain, back pain, and diabetes. I could really use help on the shoulder pain. So the resident would say, for shortness of breath, he reports he's not had shortness of breath and hasn't had any swelling. His 2-pill orthopnea is stable. His blood pressure is 118/72 with a heart rate of 62. On exam, his heart was regular, no murmurs, and he doesn't have any crackles or lower extremity edema. I was going to continue his Lasix, lisinopril, and metoprolol, and consider adding empagliflozin if we think his blood pressure can handle it. I plan to check basic metabolic panel since it's been a year since his last one. And then after each problem, they pause. I can say yes to the empagliflozin or no to the empagliflozin, or we're at the VA, let's do a different one, or whatever you want to add in. So there's really a pause after each thing. It doesn't have to be long. You can say, that's great, I agree, moving on. So you pause after that one. And then going on to diabetes, the full kind of mini soap for just diabetes, pause after that, and shoulder pain after that. Which order to present the problems in doesn't necessarily matter. There's kind of 2 schools of thought. One is you can cover all the simpler things and then end with the thing you need the most help on, or you could do the opposite. You could start with the hardest thing and then kind of speed through the last. It kind of depends on preference. If the most urgent is angina, I'd probably say do that one first. In this case, if it's shoulder pain, I like to do all the other things, like almost like check boxes first in with shoulder pain. So then that's top of my mind when we go in and examine the shoulder together. So it does not matter. It's nice to know it's coming either way. Probably super urgent should go first. And then, but other than that, that's just a little bit personal preference. So a second example, Mrs. Butler, we saw after Mr. Smith. She's a 36-year-old female with hypertension who comes in for a return appointment today. I've seen her once before 6 months ago. Today we discussed insomnia she's having, as well as hypertension and preventative health. So the opening sentence does not take very much time. And honestly, you're going to say all these things at some point in your presentation. So it's not usually adding. And then for her, they would say, okay, for the insomnia, for the last few months, she's had difficulty falling asleep at night. She leaves the TV on. Her bed partner is restless, whatever the subjective may be. And then we talked about not sleeping with the TV on, not napping late, and that's really your plan, right? So in this one, there's not a physical exam. There could be if it was snoring or neck circumference or something, but not everything has to have all of the subjective, objective assessment and plan. So sometimes, specifically objective, there may not be physical exam that goes with a complaint in clinic. So we would pause, discuss that, and then hypertension, move on to hypertension. Pause, discuss that, and then preventative health. And in this case, we did talked about pap smears given her age, and her Tdap is due in a year, but is up to date right now. And so that's been really helpful. I will say this last thing, we do finish with when do you want them back and what do you want to bill them? So it depends on your clinic. If you have to actually have the residents put in the billing codes, it's very nice to do that together. Do you want to bill them level 1, 2, 3, 4, 5 and why? Little education built in there. And then when do you want to see them back? So we try to cover that before the resident leaves, just to make sure that those return to clinic orders and everything get put in. So big bottom line, start with an overview of the patient and then one problem at a time. And then more specifically, we have the opening statement, go through each problem, mini SOAP for each problem, and then we do preventative health and return to clinic and billing level. I am going to do a few of the FAQs and then some of the post data, but I'm happy to stop at any time. So feel free to stop me. So a few that have come up over the years is residents will say, do I have to present every problem we discussed? And in general, we say no. We do want you to present the major issues discussed at this visit. And then the things to present in detail would be something the patient's worried about, something that you are worried about or have a question about, and then anything you're making a change to the plan. So what we didn't love is they were increasing their synthroid very appropriately based on labs, but they didn't tell us that. So then we see the labs and we think, oh, the resident didn't notice that or didn't mention it, but actually they did do it. So it's kind of nice. It's a little bit of talking the clinical reasoning out loud, and is great for when you give resident feedback on they catch all these small things, even if they don't need big discussions. Similar to you guys, as Dr. Logan said, we see all patients the first 6 months with interns, and so that's nice too. So we'll go in, and we, as you might expect, want interns. They have less patients on their schedule. We are happy for them to present every problem in detail. So do you have to present every problem? It's no if you're comfortable with them, but absolutely yes if it's your first day and you want to. So we are not upset about that at all. Problems you don't have to mention in detail would be stable issues without any changes. So maybe it's the synthroid hasn't changed in 20 years, or stable issues that the patient is followed by a subspecialty clinic. It's really nice to mention them in that opening statement. Patient has ESRD followed by nephrology at X location, but you do not have to go into all of the ESRD kind of screening yearly things because we assume someone else is taking care of that. That's one of them. Another question, especially for early interns, is what if I found something on physical exam that didn't have a history? And that's where we get back to every problem does not have to have all parts of the subjective, objective assessment and plan. And so it just becomes a problem. It's just one of the things you talk about. So you'll say, Mr. Jones, diabetes, hypertension, low back pain, who came in for a return appointment today. I've seen him a few times. The last was 3 months ago, and we discussed diabetes, low back pain, hypertension, and I heard a murmur on exam. So that just becomes one of the things you talk about. You probably did ask him some questions after you heard a murmur, so there may actually be a little bit of subjective, but you just add it in. You don't have to wait for a defined physical exam section of your presentation. So you just add it in. And then the question always comes up is, do I have to do preventative health every visit? And we say, yes, please. So our kind of going rule is even if you're busy and they had 400 things to talk about, unless it's someone being admitted for something, which you are welcome to ignore the preventative health that day, we do ask that residents try to address one health item each visit. I don't know how the continuity is at your resident clinics. Nationally, it's not great. Ours is definitely not great. And so if everyone punts the can down the road, then it can go like 3 years and none of the things got done. And so I'm a proponent of don't let perfect be the enemy of good. Yes, there's 10 things to do. You do not have to do 10 things, but if you could get just the mammogram ordered, that would be helpful. If you can get just the colonoscopy ordered, that would be great. If you could get one of the shots done or vaccines done. So I try really hard, no matter how busy you are, to just do one. Some of those don't require a lot of conversation. You can say, Ms. Smith, your last breast cancer screening mammogram was 2 years ago. It's time for another one. Is it okay if I order that? A lot of them don't have to have necessarily long conversations if you're short on time. So we do ask to please try, even if it's busy and you're behind. So what did we do with this? So we kind of created this. I mentioned the pre-survey in October of 2019. So in January of 2020, which is a great year to do things, but it worked out fine. We rolled it out. So I mentioned our 2 clinic sites. We have a very traditional noon conference hour where we do didactics every day. So we taught everyone that January this new presentation style and the expectation of it. We also did faculty development sessions for all of our faculty. And then every year we included an intern orientation. So I just booked it for this year. Myself and Dr. Kramer do it. It's on the calendar for one of the intern orientation sessions. And then we traditionally at the beginning had clinic champions, meaning a faculty member in that clinic that has 4 attendings that could remind people, remember we're doing this, remember we're doing this. We don't really need that anymore. I mean, it has been so well received that everyone knows and just remembers, because when a resident does not do this, it's very kind of all over the place. And they're quick to say, oh, have you learned this yet? Let me remind you how to do this. And one way we do that is with these yellow cards right here in this photo. This is actually a photo from this week. And they are so this is the room in our VA where residents come in to talk to us, and it is taped there and it stays there, and it has been, and it gets referenced a lot, which is actually really great. We have the same things taped to the desk in our university site. And so we have them everywhere, very visual. And it's funny because there's a lot of alert fatigue. There's a lot of things posted everywhere, as you can see. I'm sure your clinics are the same. But this actually gets referenced a lot, which is great. So we did all that and we're still doing it. The only thing we still do yearly is really the intern orientation. If we hire new faculty, they get told as well, but that's not necessarily every year. And so I'll go through, I mentioned we did the October 2019 survey. So then we did an October 2020 survey in order to survey the same time of the academic year, right? Because so much education happens just by living residency for a year. So we felt like a June survey would not quite capture the same type of population. So we still had a little bit of new interns and then kind of rising second and third years. So for that, this was the resident's perspective and some of the same questions. And so what you'll see is the darker the color is more confident and is better. So the same questions we had before: how confident are you in what the attending wants to hear? So the content of the presentation increased from pre to post. A lot more people confident and very confident in what the attending wants to hear in clinic. What order does the attending want to hear that information? That also improved in that 1 year. How efficient and organized, well, this was efficiency specifically. How efficient do you feel in clinic? Do you feel like it's helping you speed up? That improved. And then how organized do you feel with your presentation? That improved. So the little Facebook thumbs up are the ones that were statistically significant. We had to use a Bonfiore correction, so that's why the P value of 0.02, though normally would be significant, is not in this case because the number of questions in the survey. But it still was wonderful. And I'll just mention it is perceived efficiency. We did not go around and time people with how long it took them to present a patient. There were too many variables, unless you had someone present the same patient twice or 2 people present the same patient. So this is all perception, but still greatly improved in that. For the attending perspective, it was also improving. How efficient did you feel like the residents were? Those definitely improved. Really, everyone felt like they were very efficient or on those two highest scoring colors. How organized do you feel like they were? Much better. And then their satisfaction with just generally residents presenting to them in clinic, much better. So that was really exciting to see. So that has been really great and really helpful. We have found that we feel like it does allow for streamlined presentations of multiple chronic conditions, and helps us know what is a must addressed, what the patient was worried about, and then trying to make sure we get to those high things, even if we don't get to everything on the list. We also love that it was like learner guided, so they get to frame what they tell you, which is also a great place to give feedback. So if they tell you about three things and then you're in the chart and you find something else that seems way more important, it's also a good thing to educate them on the clinical reasoning behind that and the acuity of, which outpatient things are more acute versus not. I'll mention here that it helps you. I don't know if you guys do any formal modes of education in clinic. The 1 minute preceptor is great, like a 60-minute timer. Let me talk to you about one thing. Snaps is another great way of doing outpatient education, and those can really be included here as well, depending on if you already know how many things you have to talk about and how behind the resident is. And then personally, I definitely think this, and the faculty have felt that it really did reduce cognitive load on trying to keep all the problems in their brain that they just told you about these in the subjective portion, to also remember them when they finally get to the assessment, and to try to remember what they wanted to teach them. And so this has been great. You basically cover one, check it off, and move on. And it's really made a big difference in us feeling like we had the bandwidth to teach things. So as it was a study, strengths would be lots of phases and has been sustainable. I had the idea while putting this together just last week. I was like, we should do that same survey again, which would be so cool. So I might actually do it now, October of 2026, and see what it looks like, which would be really cool. It is, of course, just survey data. And then it is a single residency program, although I will say, because of the way we disseminated it, these are a list of the programs that I know have incorporated it and responded back to us, just telling us this has been great, or thanks, or something else. And so I can add at least the other Kansas program, maybe you guys do, which is so cool to see. And in order to do that, we think this is great. It may not be for everyone, but we'd love for everyone just to have it. And so we put it on a website. And I actually will put this in the chat here in a second. We made a whole website, and I'm going to show you that now, so that you can know exactly what it looks like. Okay. Dr. Logan, I hope that came up. I think I'm on the right screen. Okay. So I'll put it in the chat, but we made a website just because when we would go to SGIM or Aptum or any of those, people would ask, and we were like, have all of our resources. Like, we would love for people, if it helps people. So it basically describes what it is. There's also a section that says faculty development. And so there's a whole PowerPoint basically of our data before, as well as what is problem-based presentation, same type of slides that you could show faculty. And then there's another one for resident. The yellow is this one. If you click on outline, we just printed on yellow and laminated it. So this is what everyone sees that's taped to the desks, which is helpful. And then we made a few other things that I'll show you. So we made a handout. If someone's like, I don't know what you mean by any of this, here's what it is on the left, and here's an example in verbiage on the right. So that's really more for new interns. And then we also made a short note-taking page in case it was helpful. We didn't find that residents needed this, so I still have it on there. I wouldn't say most of ours need it. They kind of do their own notes and pre-rounding and pre-charting a different way, but we kind of created it in the beginning in case it was helpful. So all of those are here for anyone to use, and I hope that is helpful to people. I do love hearing when it is, which I think is great. When after we did that, I'm going to ask your thoughts. And I can talk about notes because we might have a second, but I'll still pause for.
Go ahead and talk about notes,
You want to
because
talk about notes? Okay.
anyone that knows me knows I have a lot of thoughts.
Why don't you start with your thoughts on notes? Tell me what you think.
My thoughts on notes?
Yeah, is that what you were going to say?
Oh, no, 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 not about notes in particular. No, no, the stuff that we've already talked about so far. So I was just going
Okay.
to say, just go ahead with notes and then
Yeah,
we'll
this
just,
is actually pretty brief.
perfect.
So there's a lot of, I don't know how all of you guys do your notes and how your residents do your notes, right? The traditional way is still to do, they came in with all these complaints. Here's what they said about their knee pain. Here's what they said about their headaches. And then it's very much still subjective, objective assessment and plan. And it's fine. But if you wanted to change your notes, there's a few ways. So some people do the APSO. So it's really just still SOAP, just rearranging it. And the thought there is everyone scrolls to the bottom anyway to find the assessment. So why don't we just move it to the top? So a lot of people, a lot of faculty in their private clinics will do the assessment and plan first and then everything else after. But I still feel like that's a little backwards and you might as well just combine them. And so really what a lot of people are doing now is integrated history assessment plan, all of it together. So integrating them just like they're verbalizing it to us. So a few examples of what that may look like. They'll put like kind of a one-liner, Miss Brantley, hypertension, Hep C, polysubstance abuse, who presents with ankle pain. So then here's the subjective, and then they delineate their plan. You don't have to say the word plan, but some people do, and I do think visually it helps when you're the attending looking for things. Then they went to hypertension. Here's the blood pressure today. Here's the what they're on today, and then here's my plan for today. So that's one. When people do this way, it is very helpful to have another section in your note where it says combined history plan below or combined history and plan is above, especially if you have third party coders and billers, because traditionally they only know to look in certain spots for certain things. So we found we needed, a lot of people are doing this at the top of the note. Then you get down to this part where you can, where it says impression and plan. And so it looks empty if you don't write, I already wrote it above. And so we found like that was helpful. So most people have either a little asterisk caveat at the top that says combined history and assessment below, or at the bottom to do vice versa. One resident loves to list it all out. Like, here's the history, here's the physical of that thing, here's the assessment, and here's the plan. I will say not many people do that, and not many people are this verbose, but it was a great example. So I took a screenshot of it. And then, just another one where they separate out the plan. People have all kinds of different ways, right? Some people like to bold what they're doing today versus old. And so I do think it helps combine it because it is how you are talking about it and how you're thinking about it. So I love that we're kind of getting towards that. So those are the only examples I have of notes. And I'll stop there. I will mention we loved this, and so we did publish it in JGME, which was fun to do, and got to make a visual abstract, which was also fun to do, and happy to send that. But I think the PowerPoint might actually be even more helpful. So let me, I will put this in the chat while we're talking. But yes, either Dr. Logan, your thoughts, or anyone else. I can actually start with the chat and see if anybody, yellow card. Oh, HCC diagnoses, like the high yield payment ones. Is that what they're referencing?
Yeah.
Yeah. Yeah. Yeah, that's a great question. I don't know that I have an answer to that. I think that requires, I'm not sure. So many of our faculty are kind of full academic faculty and don't have their own clinic enough to really know which of those are the most important. So that has not been a heavy topic. But I think that that would be an awesome thing to add in and would be very easy to add in. You could even add a whole HCC section. You could say, okay, before you do your preventative health, I want you to tell me, the top 10 HCCs that usually your clinic patients have. Did they have any of these, so that you can make sure to document it? I think would be an easy way of doing it. Again, don't let perfect be the enemy of good. You may not be able to cover all of them, but if you had a top 10 list, I think residents would eventually memorize it because they'd have to see it each time.
So I love it, obviously. I mean, that's the whole reason. Like, this was presented in a very small way to us, and I was like, we have to learn more. And so this has been extremely helpful. I think one of my big things that I wonder about is they have the problem-based list and they talk about things, but all these patients, I'm sure UAB is the exact same way to KU. They have a million problems. Do you encourage your residents to leave in like a chronic conditions not discussed or something like that?
Oh, in notes.
Mm-hmm.
Oh, yes, 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 definitely. I have seen that change in the about 5 years ago where they started, they wrote what they talked about, and then they wrote the words other chronic conditions not discussed today. And then they had the rest under it, whether they make it a little bit grayer or at the VA, CPRS is just black. So it's fine. But yes, I will say I also in a different, not really a different life, but at the beginning of my career, I was medical director of coding and billing for UAB. And so I'm very sensitive to that because half the stuff in there you did acknowledge, like you didn't talk about their blood pressure because their blood pressure was normal today and they had refills and you didn't need to do anything. But if you include it in that section, it discredits you for all the work you did and all the cognitive things you did. So I actually hate that when they write that because I think that it underbills, especially when third party people are billing. But we absolutely have them included all in the note. And I actually have an admission at the VA right now where it's a private VA physician, not a resident clinic, and the PCP notes are just so bare. And I was like, and we finally figured out all these great information by chart diving. But I know if it had been a resident clinic patient that had all those things still listed, we would have probably saved 2 days of an admission. So yes, the notes are long. There is some note bloat. But with the number of handoffs and the kind of poor continuity in resident clinics, I think it's necessary. I don't personally love the other things not discussed today because I do think half of them were thought about. But yeah, we do include it.
Okay. Yeah, I have like the same sentiment. I think Dr. Zhu in one of our meetings really recently, one of our other preceptors, he said the same thing. He was like, I don't put that because I know that they're on the Synthroid for their Hashimoto's and and I am looking at their TSH every time. So he's just I don't know, he's like very thoughtful about it. But I another question for me is with AI, I guess as it relates to the note portion, are you guys implementing AI in your residency? Is that affecting how people write their notes in this space and in this template?
Yeah, that's a really good question. We are implementing it approximately starting 60 days ago. So, and we're actually changing EMRs. I think we're one of the only people not on Epic. We're going to Epic in February. And so we're not putting a lot of effort into AI and notes yet because I assume it's going to change. But that said, we're using Suki. Again, I don't know if that's another one that people are using or if there's a million out there. It is doing a great job of getting everything that you say with the patient. And they kind of, it doesn't necessarily batch it like you would. They say that once you kind of edit how you like it, AI will remember that for you. And so they will start to put the assessment and the plan with the subjective portion. I'm not sure we have enough experience yet to know if it totally did that. It seems easier for AI, honestly, than trying to figure out which part goes in which section. So I guess TBD on our experience on that because I don't think we're on the front end of the AI curve personally, but I don't know if anybody is. So I don't know how it's going for y'all.
Ours is not a learning AI system. A bridge just kind of has so we use a bridge and it uses its own template and it is either a comprehensive or a non-comprehensive kind of
Mhm.
way of putting it into your note. And there's no learning from it to adapt to kind of how you do things. And so just one of I think the intricacies of what we do. Dr. Opole, you are on.
No, I've been on. No, I don't have a question.
Okay, you
Yeah,
turned
but
your camera
you
on and
know,
I was so excited. Okay.
no,
Um,
fantastic topic. I can comment. I'm one of those people who, at the bottom of my note, I say active issues not addressed.
Hmm.
And I'll tell you, some of these patients are so complicated, and every time they come in with some kind of crisis. You're dealing with an acute issue.
Hmm. Hmm.
And if you're not careful, 2 years can go by before they go and follow up on their, pulmonary nodule or whatever.
Yeah.
So I think it's for my own psychological well-being that I do that.
Yeah, and it definitely helps know what was today, like what is really on the back burner. And that's nice. It's like, oh, they do have that renal cyst, but that is not current. And I think that residents can actually get at that a different way if they just start using more dates, right? So, like, this was noted on this date, nothing to do, but you'd like it to still be there. So, my inpatient, for example, we found this lytic lesion in their femur yesterday. And so we've gone down this whole rabbit hole. Well, turns out it was there in 2017 and it's been biopsied, but it hasn't been in any PCP notes. It hasn't been in anything. And so and the way our imaging didn't go back as that far. So we had to seek it out anyway. So I do think there's some benefit to keeping those, like you're saying, in your notes and having them active to trigger your mind and not addressing it today. I think we just got to figure out the best way to include that and not have it dock your billing when you really did think about it.
Yeah, I had a very similar situation with like this diffuse, very large lymphadenopathy, and I was like, "Why haven't we done anything about this?" And my resident was like, "I don't know." And it was actually something had been done about it 5 years
Mm-hmm.
ago, and it was just not
Mm-hmm.
continued anywhere. And then and then I was like, I know. And then it's just like so all-consuming for like 30 minutes before you realize, oh my gosh, it
Yeah.
literally had biopsies and yeah.
Yes. Yeah.
Okay, so when you're going through the chart and you're pre-charting on their patients, when you come in after the presentation, where do you add, hey, I noticed this. Let's
Mm.
talk about that.
Mm-hmm. So two places. One, I always pull up the patient as they're talking, and kind of multitask, like listen to them and also kind of look at the last note. And I usually orient my notes by date. Some people batch them by type, but I organize them by date so I can see everything that's happened since the last PCP visit. Like, did you realize they saw surgery? Did you realize they were supposed to see surgery? And there's a note that says they no-showed, things like that. So I would 80% of the time, I add it in at the end because I also want them to finish their presentation before I start peppering them with questions, because they may be about to say what I'm going to say just in a different order, and I want to give them the benefit of the doubt. So it's usually at the end, and I'll say, okay, can I add a few things I just saw? And then the other 20% of the time, it's not till I'm signing their note and I happen to be looking a little bit deeper, in which case it's a conversation, kind of a separate time. They may still be there just in the afternoon session now, and so I can go and circle back. And sometimes it's an email to say, I just noticed this. We should probably move this forward and not wait till the next visit. Does that help?
Yeah, no, that makes a lot of sense.
Mm-hmm.
Um, and then, but you're like on every single SOAP mini section, you're discussing each thing in detail. And do you educate? Like, is that where you throw in your education, or do you really get to the nitty-gritty of plan? Do you wait till the end of all of the different things to talk about your main educational point?
I do it as we go. Like I really just pick one thing and I'll say, okay, it's hypertension, new hypertension guidelines, all these other things. Can we talk about that real quick before we get to the next two things? And I kind of give them an out to make sure that they told me all the three things we're going to talk about. So there isn't something secret hidden that you haven't mentioned. And so I do it as we go because I think that's the benefit is you now when you talk about illness scripts, I don't know if y'all use that term in clinical reasoning, right? You've opened up the file folder in your brain for hypertension. You just told me your hypertension plan. So now I'm going to give you some hypertension education then before we move on. I think it sticks better that way. But I try not to do that for everything because some other times people will be like, it takes forever if I always go to Dr. Steinhilber or whoever because I love the teaching, but they teach every time. And so I try to be understanding of that and keep it bite sized and short and maybe just one thing per resident, unless there's just some wrong things that we need to correct, right? Some wrong information or some wrong medical knowledge.
Okay, awesome. Okay, I'm going to be quiet. I'm going to open it up just to make sure no one else has any burning questions. Okay. I'm not good at the 10-second pause. Anyone can email me and I'd be happy to coordinate with Dr. Steinhilber if there's any like major questions about this, but we can't thank you enough for coming. It's so nice to kind of like hear your rationale, especially at the onset. You developing this and bringing it to us is so nice. I will send you a message when this gets implemented and let you know.
Oh, good. And sorry, I'll have one last comment that I forgot to
Yeah.
say. We would love to move this upstream. Like we're so GME heavy. I think you guys probably are very GME heavy. I think the best thing that could happen is eventually this is like what UME teaches people. It can be in family medicine or wherever they have their core outpatient rotations. Because I think the students could benefit a ton. And so we're trying to work on that too. But so it's not just resident related as you would probably not even assume, but
yeah, I mean, like my mind goes to resident, but it's interesting because the implementation data before it even started was all from UME. It's from people transitioning into residency. So all of so it's very, very interesting. And like the handout that you had, that you were like, no one really uses it. It seems like that would actually be a lot better for a medical student with a clipboard and like, yeah. So I think I am actually, I thought about that. I think I am going to bring it to my, at least my urgent care clinics with my medical students for sure.
And I think more people would be willing to precept students if the students, I'm going to say this very bluntly, didn't slow them down as much. And one way to help that might be to get them more organized on the front end.
Yeah.
Because it's hard. It's just a hard thing to do. It's a hard thing to learn.
I was talking about it yesterday with someone.
I know. I bet.
So,
Thank you, everybody. It was so good to see so many faces.
Yeah.
And yeah, let me know if I can help.
Cool. Thank you so much. Bye.
You're welcome.
Bye,
Bye.
everyone.